Frozen embryo transfers can happen weeks, months, or even years after the embryo was created. In fact, there was actually the longest frozen embryo that resulted in live birth of twins, and embryos were frozen for 30 years before the transfer occurred. And again, twins were born and they're happy and healthy.
That is amazing. That is science at its best, right there.
Welcome to My Fertility podcast, Superhumans, the show that brings you expert insights, personal stories, and the latest in fertility care all in one place.
Whether you're starting your fertility journey, navigating challenges, or just exploring your options, we're here to empower you with knowledge, support, and hope.
Join us as we dive deep into topics that matter most, from IVF and fertility treatments to mental health and wellness.
I'm Dr. Mavis Garcia.
And I'm Dr. Wise. We're two of the fertility specialists at Markham Fertility Centre in Markham, Ontario, Canada. Think of us as your sisters in all things fertility. Let's demystify the world of fertility together.
Hello, superhumans. We are so glad that you're joining us today for another episode of My Fertility podcast. The topic for this episode has been very widely requested. We're going to be talking about frozen embryo transfers, otherwise known as FETs. If you're interested in learning about fresh embryo transfers and you're not necessarily listening to our show in order, which we totally get, please refer back to episode 67, where we talk about fresh embryo transfers part 1, which is the procedures, timelines, the pros, and the cons.
That was a really good episode, if I may say so myself. I think it was super informative and highly requested as well. We're also going to be releasing a part 2, so stay tuned for that. On today's episode, we're going to be doing a deep dive into explaining frozen embryo transfers and what are the 3 main types. Spoiler alert, we're going to talk about natural cycle transfers, medicated transfers, and stimulated transfers. And there are no guests today. It's just going to be the two of us chatting and answering your common questions all about frozen embryo transfers.
All right, so let's start at the beginning. A frozen embryo transfer means we're transferring an embryo that was previously created and frozen during an IVF cycle. We're thawing it to place it in the uterus and hope for implantation. If you want to listen to previous IVF episodes, we are referencing episodes 14, 20, 54, and 58.
Exactly. So frozen embryo transfers can happen weeks, months, or even years after the embryo was created. In fact, there was actually the longest frozen embryo that resulted in live birth of twins, and embryos were frozen for 30 years before the transfer occurred. And again, twins were born and they're happy and healthy.
That is amazing. That is science at its best, right there.
Absolutely. It's kind of trippy though, too.
For sure.
Yeah, very like Matrix or like Inception-esque.
Frozen embryo transfers have become incredibly common, and they now account for the majority of embryo transfers happening at many fertility clinics around the world. Here at Markham Fertility Centre, I would guess that approximately 85% of the embryo transfers that we do are frozen embryo transfers.
And there are so many reasons for that. So one of the big ones for sure is flexibility. In a frozen embryo transfer, we have more time to optimize the uterine environment. So it allows us to delay a transfer, let's say if there's a medical concern during the IVF cycle or a concern about the uterus, or if we're doing genetic testing, otherwise known as pre-implantation genetic testing or PGT, let's say it's being done on the embryos. If you're interested in hearing more about PGT with our amazing genetic counselor, check out episodes 30 and 36 of the podcast.
Another reason to do a frozen embryo transfer is to reduce the risk of ovarian hyperstimulation syndrome, which can happen during an IVF cycle. Ovarian hyperstimulation syndrome is a complication that can occur after ovarian stimulation in IVF, and it happens when the ovaries respond really well, like too well, to the fertility medications, leading to swollen ovaries and fluid into the abdomen and sometimes even in the chest. In severe cases, it can even lead to hospitalization. We can do a whole episode on this, but it's not quite ready yet. So for now, just understand that ovarian hyperstimulation syndrome can worsen in pregnancy because the pregnancy hormone ACG can intensify and prolong the symptoms of OHSS. So by freezing embryos and delaying transfer to a future cycle, we give the ovaries time to return to the normal size and function, and doing a frozen embryo transfer significantly reduces the chances that ovarian hyperstimulation syndrome will become more severe and life-threatening.
The other thing worth mentioning is that freezing technologies have come a really long way. So, with something called vitrification or flash freezing, embryo survival rates after thawing are excellent. And the literature suggests that it's like over 95%. I would say that we generally have a really low threshold for freezing embryos because we're so confident in the freezing technologies and frozen embryo transfers.
I think it's also important to note that not every embryo that is created in an IVF cycle can be frozen. And what I mean by that is if we go back to those episodes on IVF, eggs are retrieved and they're fertilized. And then over the next 5 days, those fertilized eggs need to develop into blastocysts. Now, not every fertilized egg is going to develop into a blastocyst. Approximately only about 40 to 50% of fertilized eggs develop into a blastocyst, but only embryos that achieve that blastocyst stage, which means an embryo that is fully expanded, it has an inner cell mass, and it has a trophoblast around it, it's only those embryos that can be frozen. Embryos that don't continue to develop and don't make it to the blastocyst stage are not frozen and they are discarded because they're not considered viable embryos for freezing and thawing and subsequent embryo transfers.
So let's get into frozen embryo transfers and fresh embryo transfers and the pregnancy rates and how they may be a little bit different. This is a very, very common question that patients will ask, right? Like, what is going to yield a better pregnancy rate, a higher pregnancy rate? It's important to keep in mind that in a frozen embryo transfer, an FET, that allows for an endometrial preparation that might be a bit more of a physiologic hormonal environment. So, what does that mean? In a frozen transfer, we're not necessarily having those super high levels of estrogen and progesterone that result in an IVF cycle. These super high levels of hormones may negatively impact the ability of the endometrium, which is the lining of the uterus, to be receptive or sticky to an embryo and may affect the implantation of an embryo. In fact, there's been large trials, large studies that have demonstrated that in a frozen embryo transfer, you may have similar or potentially even higher live birth rates, and of course, lower rates of OHSS, which we had talked about a little bit earlier, compared to a fresh transfer, especially in women who have PCOS or people who are high responders, meaning they do IVF and they get a lot of eggs.
For example, there was a study published in the New England Journal of Medicine, and I know that you have heard us mention that journal quite a bit because it's one of the top journals in medicine. This was in 2018, and it was a transfer of fresh versus frozen embryos in women who are ovulating regularly. And it found that the live birth rate did not differ between frozen embryo transfer and fresh embryo transfer. And there was also no significant differences between rates of implantation, clinical pregnancy rate, overall pregnancy loss rate, or ongoing pregnancy rate. However, frozen embryo transfers resulted in a much lower risk of ovarian hyperstimulation syndrome compared to fresh embryo transfers. Risks of obstetrical and neonatal complications and other adverse outcomes were completely the same between fresh and frozen embryo transfers.
And that leads to another really important point because not only are we doing a transfer with the goal of that positive pregnancy test, but we also want the healthiest pregnancy that we can, both for the person carrying the pregnancy and for baby. That leads to the next question about what are pregnancy outcomes like when we're thinking about fresh versus frozen embryo transfers. Does it affect the pregnancy itself? Generally speaking, frozen embryo transfers are associated with lower rates of preterm birth and lower rates of low birth weight compared to fresh embryo transfers. There have been multiple large cohort studies and meta analyses that have consistently shown that a singleton pregnancy, meaning one baby, after FET have a reduced risk of preterm birth and low birth weight compared to those after a fresh ET or a fresh embryo transfer. However, it's interesting to note that frozen transfers may be associated with high rates of large for gestational age babies and macrosomia, or a big baby. So, frozen embryo transfers might increase your risk of having a big baby. Fresh transfers might increase your risk of having a smaller baby. There was a very large study called Obstetric and Perinatal Outcomes after either fresh or thawed frozen embryo transfer, where they looked at over 112,000 singleton pregnancies. And this was published in Fertility and Sterility in 2016. And these are some of the findings that came out of that study.
So, for context, low birth weight is an indicator of placenta issues. Generally speaking, when talking about high incidence of low birth weight, we are talking about high incidence of possible placenta related complications or placenta insufficiency, which is usually what causes low birth weight.
And low birth weight is important because babies born with low birth weight may have some trouble maintaining body temperature. They may have difficulties feeding or gaining weight when they're born, and they might be slightly higher risk of infections or breathing problems at birth. In these studies that we've talked about, we're talking about these really big, large registry studies where they're looking at a wide swath of the population. But again, it's really important to consider the specific patient and the specific embryos when we're talking about pregnancy rates and what could be better for a specific patient. So, just as Dr. Garcia said, not every embryo is freezable, but again, at MFC, we would certainly consider doing a fresh transfer. You can't necessarily compare the pregnancy rates for a fresh transfer for a poor quality embryo to a frozen embryo transfer pregnancy rate for a much better quality embryo. And then, of course, there's also PGT, which again, we've talked about in previous episodes. And a PGT tested embryo, specifically a euploid embryo, has a much higher success rate in general as well. This is all to say that there is so much nuance and there's a lot of pieces that go into the puzzle of trying to decide what the expected pregnancy rate is, how we look at that, and then try and determine what may be better, a fresh versus frozen embryo transfer for the patient in front of us.
With that being said, now that we have frozen embryos ready to go, the question becomes, what is the best way to prepare the uterus to receive one of these precious frozen embryos?
And that brings us to the three main approaches that we use. Generally speaking, we have natural cycles, we have medicated cycles, and we have stimulated cycles. Now, each of these have a whole bunch of different synonyms, but we're going to dig into each one.
A natural cycle frozen embryo transfer is exactly what it sounds like. We track your body's natural menstrual cycle, and the time of the embryo transfer has to match the time of your own ovulation. Specifically, embryo transfer happens about 6 days after the natural LA surge and is documented by a series of blood work and ultrasound so that we can figure out exactly what is the optimal time for embryo transfer based on when ovulation was confirmed.
At MFC, we freeze embryos at the blastocyst stage. So again, we do the transfer about 6 days after ovulation. Why is this? Because in a spontaneous pregnancy, this is naturally when a blast or blastocyst would be implanting into the wall of the uterus. Essentially, this is when we believe the uterine lining is quote unquote most sticky to an embryo. Pretty elegant, right? Now, if you're even more interested in hearing about the endometrium and the lining of the uterus, please have a listen to the episode that we did with one of our favorite guests, Dr. Chan. That was episode 11. Now, it's worth noting that we don't change the day of the transfer based on whether an embryo was frozen after 5, 6, or 7 days from the retrieval. So, why is that? Well, because we're optimizing the timing of the transfer for the uterine lining, not necessarily based on the embryo. So, again, if the embryo gets to blastocyst stage, day 5, day 6, or day 7, we group them together essentially, and then we're timing it to the uterine lining.
One of the big advantages to a natural cycle frozen embryo transfer protocol is that it avoids taking extra hormones. For a variety of reasons, some people feel strongly about minimizing medications of hormones during their IVF treatment. And with the natural cycle, your body is producing its own progesterone and estrogen. Here at American Fertility Center, we routinely put patients on extra progesterone around the time of the embryo transfer, and we do this to supplement the natural progesterone that the corpus luteum in the ovary is producing. And if you don't remember what the corpus luteum is and the time of the menstrual cycle when you're producing progesterone naturally, please refer to episode number 2, the menstrual cycle.
The addition of extra progesterone in these natural cycle frozen embryo transfers has been shown to significantly improve pregnancy outcomes compared to not using extra progesterone. There have been multiple randomized control trials, meta analyses showing that giving progesterone post ovulation increases live birth rates, clinical pregnancy rates in these natural cycles without increasing miscarriage rates or the risk of adverse perinatal, obstetrical, or baby outcomes. There was a study titled The Effect of Progesterone Supplementation for Luteal Phase Support in Natural Cycle Embryo Transfers that was published in Fertility and Sterility in 2023 that showed this. There was another study published in Human Reproduction in 2022 called Progesterone Supplementation in Natural Cycles, showing that it improves live birth rates, and many, many more.
So, what type of progesterone is best in a natural cycle? Well, we have vaginal progesterone, oral progesterone, and progesterone oil injections to consider. As mentioned in the studies referenced above, vaginal progesterone is considered the most effective and widely used formulation for luteal phase support in natural cycle frozen embryo transfer protocols. There is really good evidence from randomized controlled trials and meta analysis demonstrating that it improved the live birth rate and the clinical pregnancy rates compared to not using any progesterone at all.
Now, the evidence for using intramuscular progesterone injections or IM progesterone injections for luteal phase support is actually really limited. So, there's just not many studies that have specifically looked at progesterone injections in a natural cycle frozen embryo transfer. Again, most of the high quality studies, meta analyses that are out there have really focused on the vaginal micronized progesterone, as we've mentioned earlier. There is very, very limited direct comparison data between IM progesterone and vaginal progesterone in this specific subtype of embryo transfer cycles.
Yes, and I know that you said it, but I'm just going to say it again. This applies to natural cycled frozen embryo transfer only. This statement does not apply to other types of frozen embryo transfer protocols, which we're going to get into later in the episode. And the reason that I'm repeating it, even though Dr. White so clearly stated, is because there is a very important distinction between a natural cycle and a medicated cycle. We're going to go into more detail in a medicated cycle, but let's just say that in a medicated cycle, you're not making progesterone like you are in the natural cycle. Therefore, there is better evidence for using progesterone oil in that setting in a medicated cycle. Now, here at American Fertility Center, I do have a lot of patients that are using the progesterone oil injection in a natural cycle, even though we just told you the evidence doesn't suggest that it's better or worse. One of the reasons people do that is because it is once a day injection versus having to do vaginal suppositories twice a day. Also, some people don't like putting something in their vagina, and they also avoid the discomfort that may come with the vaginal discharge associated with vaginal progesterone. I have to confess that I sometimes worry that people hear that progesterone oil injection is better in a medicated cycle. And of course, our patients really want the best outcome. Therefore, they extrapolate that information to a natural cycle and then request using progesterone oil in a natural cycle. And I don't have a problem with that. There is nothing wrong with using progesterone oil injections as long as you're aware that the evidence is very positive for progesterone oil injections only in a medicated cycle, not in a natural cycle.
Natural cycle FETs sound great, but they do have their drawbacks. In a natural cycle frozen transfer, you really need precise timing and way more frequent monitoring. So, more clinic visits in the form of these cycle monitoring appointments. We are trying to nail down the timing of that big LH surge. And sometimes that LH surge timing's just not really clear, or sometimes patients will have anovulatory cycles, even though they have a history of regular cycles. And in those situations, there really is no LH surge. And when this happens, we have to cancel the cycle and we kind of go back to the drawing board, meaning that you're going to have a follow up appointment with your doctor to discuss next steps. Sometimes that could be a second attempt at a natural cycle or a different type of cycle, which of course we're going to address shortly.
Also, a natural cycle doesn't work well for people that do not have regular periods. So, if you have irregular cycles, such as, for example, polycystic ovarian syndrome, or if you are perimenopausal or in menopause, then a natural cycle is really not a good alternative for you. In situations like that, a medicated cycle or a stimulated cycle might be a better option. If you want to remember what PCOS is all about, refer back to episode 16 and 21. Another reason to choose medicated cycles versus natural cycles, as Dr. Weiss mentioned, there is more frequent monitoring in a natural cycle so that we can nail down the exact time of ovulation. For people who live far away from a clinic, that becomes a problem, having to drive to the clinic, multiple times in a cycle. In a medicated cycle, you don't have to do the frequent monitoring. So it becomes a very attractive alternative for people who live far away and don't have the ability to go for regular cycle monitoring at a fertility clinic.
And big news, as of August 2025, we are bringing fertility care closer to home. We have our Markham main location, of course. We have a location in Barrie, Sudbury, Oshawa, and Aurelia. You can find out more information about these locations and the services we offer at markhamfertility.com/locations. Let's move on to the medicated cycle, or what's sometimes called a hormone replacement therapy cycle, or HRT, FET, or medicated FET.
In this approach, we essentially take over your body's hormone production. We're no longer relying on your body's ovulation anymore. Instead, we give you estrogen to thicken the uterine lining. And then once we know that the uterine lining is at a certain level, then we add progesterone to make the lining receptive to the embryo. In fact, a medicated cycle actively suppresses ovulation, which is why it's great for patients that have anovulatory cycles or patients who live really far away and cannot do monitoring routinely.
Yes, a medicated FET is very controlled. You can schedule the transfer more predictably. And as we said, it works much better for people with irregular cycles or who don't ovulate, let's say, every month. Again, it's a great option for patients who live far away from the clinic where they might need to be scheduling things like flights, hotels, etc. Because in a medicated cycle, you have the flexibility to kind of shift the timing a little bit. So, for instance, we can extend out the estrogen or start the progesterone a couple days later, let's say, to accommodate a schedule to be able to try and work with the patient and their schedule and the timing of the transfer.
Now, the downside of a medicated cycle is that, as the name suggests, it does require taking more medication. So that would include pills, patches, potentially injections, and that could be a downside for some people. Every clinic is going to be a little different on their approach. Some clinics do all of their cycles medicated. Here at Markham Fertility Center, we offer all three types of frozen embryo transfer protocol: natural, medicated, and stimulated. And for the medicated cycle, we use a combination of estrogen pills and an estrogen patch to thicken the lining.
Also at MFC, we typically recommend progesterone injections in a medicated cycle frozen embryo transfer. There have been many high quality randomized trials that have shown that live birth rates are significantly higher with these intramuscular progesterone injections compared to vaginal only progesterone regimens, with vaginal only protocols associated with a slightly higher rate of miscarriages and lower live birth rates. In 2021, there was a study published in Fertility and Sterility called Intramuscular Progesterone Optimizes Live Birth from Programmed Frozen Embryo Transfer, a randomized clinical trial. In this study, they looked at over 1,000 frozen transfers and they compared IM progesterone versus IM progesterone with vaginal progesterone, and then just a vaginal progesterone. The live birth rate was significantly lower in women who received only vaginal progesterone, that was 27%, than in women who received IM progesterone, where it was 44%, or combo treatment, where it was 46%. That's a really big difference when we're talking about 27% versus 44 and 46%. As well, in the study, they found that 50% of pregnancies in women who only got vaginal progesterone ended in miscarriage. So the study seems to suggest that doing a combo regimen, the vaginal plus this injection every 3 days, is non inferior, meaning it appears to be not worse to doing daily progesterone injections. And again, this can be a really good compromise because it may reduce the burden of doing all of those injections while maintaining those really good pregnancy rates.
Yes, because let's be clear, progesterone oil injections are not easy. And I speak from personal experience as well as professional experience. Unlike the IVF medications, which are done subcutaneously, progesterone oil injections are done intramuscular. That means the needle is longer because it has to go deeper into the muscle. The fluid, the oil, it's thick, which makes it more painful and more difficult to apply. Also, you generally need somebody else to do it for you. Like again, the IVF medications, you can do it in your belly. It's a tiny little needle. It's just going on the skin. You can do them yourself. Because the IM injections for progesterone oil have to be done in the gluteus, then it's a lot harder for you to do it yourself. So then you need somebody there to do that for you. And there is a whole process. There's many tips and tricks that can be used to minimize the discomfort, and our amazing nurses at Mark and Fertility Centers are really good at going through all of that. They would put a marking on the gluteus area and they would show you all the tips and tricks that you can do to minimize it. But at the end of the day, they really are painful.
Now we're going to talk about the third option, which is a stimulated cycle. The way that I think about this one is that it's a bit of like a hybrid between a natural cycle and a medicated cycle.
That's right, because in a stimulated cycle, we use medications. They could be letrozole, which is an oral medication, or they could be injectable gonadotropins to encourage the body to create follicles and ovulate. And then we track that ovulation like in a natural cycle. So, yeah, you're absolutely right. It's a hybrid between the two.
A stimulated FET is a great option for someone who isn't reliably ovulating on their own, but where we still want to use the body's own hormonal rhythms. So we support the cycle with medications to kind of induce or kickstart that ovulation process, but we're not replacing the hormones entirely like we do in a medicated cycle.
Letrozole based protocols are becoming more popular because they seem to mimic the natural hormonal environment better than a fully medicated cycle. In women who are ovulating, letrozole stimulated frozen embryo transfers can yield a live birth rate that is comparable to natural cycles and consistently higher than medicated cycles with estrogen and progesterone.
There was a study in fertility sterility in 2022 looking at over 3,000 FET cycles at ongoing pregnancy rates or live birth rates. They were comparing frozen embryo transfer cycles. The cycles used were the letrozole ovulation induction cycle, a natural cycle, and a medicated cycle. So the pregnancy rate, live birth rate was higher amongst the letrozole FETs than amongst the medicated FETs, and it was comparable to the natural FETs. The risk ratio was about 1.11 when we looked at the letrozole FETs versus medicated FETs, meaning that the chance of pregnancy was about 1.1 times higher in these letrozole frozen transfers than in a medicated frozen transfer.
The study that Dr. Weiss mentioned refers to women who are ovulating regularly. Women who have anovulation or polycystic ovarian syndrome, letrozole stimulated cycles are also favored over medicated cycles. As a matter of fact, there was a meta-analysis and recent systematic reviews that shows a modest but statistically significant increase in live birth rate and a reduction in miscarriage rate and high blood pressure disorders of pregnancy in women that have anovulation and use letrozole instead of a medicated cycle for a frozen embryo transfer protocol.
Yeah, so this was a really cool study that was published actually this year in 2025 in Human Reproduction Update. And it was called Reproductive Outcomes After Letrozole Stimulated versus Artificial Frozen Thawed Embryo Transfer Cycles, specifically in women with PCOS and or anovulation. This was a systematic review and meta-analysis where they looked at 74 different studies. There were over 8,000 women who did letrozole FETs and almost 17,000 women who did medicated FETs that were included. When they did a meta analysis comparing these letrozole FET versus a medicated FET, they showed a modest, but again, statistically significant increase in the odds of live birth. There was a 1.37. When they looked at the odds of pregnancy loss or miscarriage, they found that in a letrozole FET, the risk was 0.63 versus a medicated transfer. So again, the risk was lower in a letrozole frozen transfer. Now, it's worth noting that the authors did note that the quality of the evidence remains low and that more well designed randomized control trials are needed. So, even though this was a lot of women that were included in this study with a lot of transfers, if you're putting in not great quality data into meta analyses, we can't necessarily 100% believe the results. So, again, more studies are still definitely needed.
Now let's talk about gonadotropin stimulated frozen embryo transfer. A gonadotropin stimulated frozen embryo transfer can yield reproductive and surgical outcomes that are very similar to those of a natural or letrozole stimulated cycle. A gonadotropin stimulated frozen embryo transfer means that instead of using letrozole, we would be using gonadotropins. Those are the same injections that you would use during IVF, usually in a lower dosage, to stimulate the ovaries to make one or two follicles, which would then be triggered for ovulation. And then an embryo transfer would be timed based on when that ovulation happened. A large registry and cohort studies report that the reproductive outcomes, such as pregnancy, ongoing pregnancy, and live birth rate, are equivalent between natural cycle, letrozole stimulated cycle, and gonadotropin stimulated cycles. And this was noted in the same study that we mentioned earlier, published in 2022 on fertility and sterility.
The downside of these types of cycles is that, like in a natural cycle, involves more monitoring, so more cycle monitoring appointments, and the timing can still be a little unpredictable. There's a higher risk of cancellation if someone isn't ovulating, or if we don't feel super confident being able to pinpoint when ovulation occurred. The other big thing with injectables is that, of course, you're taking daily injections, but the costs go up a lot once we're factoring in the cost of injectable gonadotropins on a daily basis. It's not the same as the cost as, let's say, in an IVF cycle, because as Dr. Garcia mentioned, the dose is much, much lower. But that still is an important factor when we're weighing all of our different options.
And speaking of options, having spent some time talking about the different types of protocol, let's talk about how we decide which approach is right for the patient sitting in front of us.
This really depends on so many things. First of all, we're going to think about cycle regularity, like menstrual cycle regularity, somebody's comfort with medications, with vaginal medications versus injections versus oral medications, somebody's medical history, past IVF cycles, past transfer outcomes, and then just the practical stuff like logistical concerns when we're thinking about travel schedules or a person's ability to schedule, let's say, cycle monitoring appointments and scheduling.
Some people, for example, have a strong preference to avoid hormones. And then for them, if they're ovulatory, a natural cycle would be a great option and they might not mind traveling. Others, on the other hand, love the control of a medicated cycle because it's better for their schedules to be able to have more flexibility in when to book the frozen embryo transfer. And others might have conditions like endometriosis or a thin endometrial lining, and that might make one protocol preferable over another.
At MFC, the vast majority of first frozen embryo transfers are natural cycles. And I would say that this is our go to, really. That being said, we always, always, always will try and personalize the approach. And it's okay if it takes more than one try. So I always tell patients, even when we cancel your frozen embryo transfer cycle, it's important to know that your embryo is super safe and totally undisturbed. We do not do anything with the embryo until the actual day of the transfer. So even if it takes us 2, 3 attempts to be able to get to that point of scheduling the FET, there's no downside for the embryo. There's no risk to the embryo. Now, of course, once you've decided to do an FET, nobody wants to wait an additional 3, 4 months, but the embryo is safe. And, really, sometimes from that first transfer attempt, we learn a lot and then we adjust for the next one.
I think it would be important to note, of course, the safety of the embryo in a cancel cycle is number one, but also in terms of financial implications, you're not out the money that you've paid for an FET. If it's a funded cycle, you still have a funded embryo transfer. If it is not funded and you're paying for it, you either get a refund or a credit gets applied for when you actually do your frozen embryo transfer. The actual cost for you would have been the time that you took to come to the clinic and do the monitoring and the cost of the medications that you may have taken.
So we've covered a lot of information in today's episode all about frozen embryo transfers, but we recognize there's still a lot more to talk about. There is going to be a part 2 to this series. And in part 2, we're going to be talking about the procedure and sort of what actually happens and what it's actually like, specifically here at Markham Fertility Center. And we're going to be answering a bunch of your frequently asked questions when it comes to frozen embryo transfers. And that's a wrap for today, superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music from Mixkit, Life is a Dream by Michael Ramirez C.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.